Hello and welcome to lymphatic and visceral manual therapy. This is the pre-class lessons, and I've also called it functional fluid flow. And the reason I did that was because the way that the fluid flows within the body can affect the function. It can reveal how the body's functioning, and if you change the fluid flow, it can change the function. And I say that not lightly, but we can measure it and we can change it. Now, this class is brought to you by myself, Greg Day, sports physiotherapist, and I'm one half of Performance Physical Therapies, where one of the pillars that we have is that performance is a behavior that we can change quickly. And performance is an output that we can measure quantitatively, but also we can rate it qualitatively. And it's this ability to look at the human body as a behavior or a set of behaviors, which we also describe as a performance, and reveal when we consider it to be acceptable or not, and then to be able to change it. And this course came about due to observations that the lymphatic and visceral system has a very significant place to play within the function of the body. So let's carry on and continue. So we have this circumstance where, as clinicians, we treat many biomechanical conditions that may not be driven by causes or contributors or complicating factors that we would commonly see. And in fact, anecdotally, in the past 5 years, one of the things that I have noticed is that in 9 out of 10 individuals with musculoskeletal pain, in addition to their local or their regionally interdependent causes or contributing factors or complicating factors, the lymphatic and visceral system plays a very significant role in their movement behavior and musculoskeletal pain. So in the class, we're going to look at a number of lessons, and the first one is that we want to review some basic anatomy that's relevant to the lymphatic and visceral systems. We will learn some of the critical factors, meaning the things that are definitely related to the health and function of the lymphatic and visceral system. We'll also understand how these factors relate to movement and musculoskeletal pain. We will perform baseline movement assessments, and we'll perform baseline lymphatic and visceral assessments. Then we'll learn how to treat the lymphatic and abdominal viscera, and we'll listen and feel for the tells that the lymphatic system and the visceral system is changing its behavior. Of course, once we detect those tells, we can then go back to our movements and musculoskeletal pains, our special tests, our assessments, our breakouts, our local biomechanical evaluations, and reassess whether they have changed as a result of the things we did with the lymphatic and visceral systems. We'll finally learn to reinforce the strategies and using some exercises as well to maintain improvements in those musculoskeletal movement patterns and pains, and also improve the lymphatic flow and visceral flow. When we kickstart the basic anatomy that's relevant to the lymphatic system, we're going to start with the brain. Now, the brain lymphatic system is known as the glymphatics. It's a fluid exchange system. It's also useful for clearing waste out of the brain. It goes into the neck. It's driven by three main things, which is heart rate, breathing mechanics, and also the pulses of each of the blood vessels inside our brain. If you have dysfunction in the brain clearing system, it can relate to neuroinflammation. That's got a range of different symptoms, as well as synaptic plasticity, which means how you can change your nervous system in the brain, memory, and learning. These are all relevant to some of the symptoms that we see in people with lymphatic dysfunction. So when you get a buildup of neurotoxic waste in the brain due to a glymphatic dysfunction, then we lead to a range of symptoms as just described. But we need to know, where does this waste drain to? Well, it goes through a part of the back of the nose called the cribriform plate. It drains through there to the cervical lymph nodes and eventually back into the circulatory system. Let's have a look at what the research tells us, because there's some detail around this glymphatic system that's really important. Now, we need to know more about where this neurotoxic waste goes and how it gets there, because there's some relevance here. Now, interstitial fluid in the brain parenchyma. Okay, so the brain parenchyma is this area here, and it drains along the basal membrane within capillaries and major arterial branches. And then it moves towards the leptomeningeal arteries at the surface of the brain. So we're talking about this type of area here. And it eventually enters the cervical lymph nodes of the exterior skull base. Let's have a little look at the video of how it gets there through the cribriform plate. So here's our human skull. We're going to take a little bit of the skull away and we're going deeper into the frontal sinuses. We're going to go a little bit behind the eye. We've taken away the maxilla bone and the maxilla sinuses. We're going to remove the nasal bone and we're going to go a little bit deep into there. So we've taken away some nasal sinuses. We're getting underneath the frontal lobe and we're going to spin this around a little bit. Now you're going to see a couple of yellow sort of optic nerves here. That's these fellas. Okay, that's them there. Well, just beneath it showing up in blue, that was the cribriform plate. We have another look at it. We've got the nasal sinuses and the frontal sinuses, and the cribriform plate is that light blue structure deep in there. You see it's got a lot of holes in it. That's where the olfactory nerves go. Now, once it drains from the brain, we're looking at drainage along the veins of the face through to the cheek. So we've got these cheek lymph nodes and then the mandibular lymph nodes. We've got some parotid gland lymph nodes and we've got these jugular vein lymph nodes as well as the sternocleidomastoid lymph nodes through here. Obviously there's a few around the back of the head as well. Those are the superficial ones. If we look deeper, we can see where they sit. They're all parallel to the spine. Some around the thyroid as well, and the trachea, and of course around the tongue and under that jawline. That's relevant because of our ability to palpate some of these areas. If we can palpate it, then we can test them for signs that the lymphatic system may be dysfunctional in some way. Now, all of those lymph nodes, they're along the line of the sternocleidomastoid muscle. Well, not all of them, but the ones that we can influence a lot, they, if you can decongest them, can give you some space for those facial lymph nodes and the tongue lymph nodes to drain into. Of course, once you do that, they're going to enter the right lymphatic trunk. So even whether it's the left-hand side of the face and the head, they're going to all enter the right lymphatic trunk. Then they're going to enter into the superior vena cava and the subclavian vein, head on into the aorta from there. So let's have a little bit more of a look inside the brain because there's some more relevance here. So we've now got a snapshot of the interface between the arteries and veins and the lymphatic system inside the brain. These flashing arrows are pointing to an astrocyte. Now an astrocyte is a subtype of brain cell or a macroglial cell. It has a typical star shape and it exists in different regions of the central nervous system. Further, the astrocytes are located at vessels and they have special vascular end feet attaching to the outside of the capillary walls. Now, the aquaporin 4 water channel, it's pretty important. We're going to come back to this in the live class and why it matters, but it's abundantly expressed by astrocytes and it's highly polarized to the astrocytic vascular end feet processes. It's got bidirectional water capability transport. So the water flows in both directions. So the complex that's formed by the astrocyte, the end feet process, and the aquaporin 4, they're all very, very important because they contribute to the exchange of solutes and metabolites between the cerebrospinal fluid and the interstitial fluid. Here's a fun fact for you. The aquaporin water channel, it takes part in the clearance of beta amyloid, which by regulating cerebrospinal fluid. Now, beta amyloid is implicated in Alzheimer's disease. Let's come back to that later because memory difficulties is one of the signs that a brain may not be draining lymphatic fluid. If we have a look at the question, what contributes to the flow between the interstitial fluid of the body and the cerebrospinal fluid, it's a really important question because if I've gone to all this trouble to explain the aquaporin 4, the astrocytes, the cribriform plate, and the lymphatic system, it must be because there's a link between brain drainage and the interstitial fluid of the body. Because remember, we are in the business of changing musculoskeletal movement and pain, so there is a link. Let's look at what contributes to that exchange. So the things that contribute to the flow of fluid between the interstitial fluid and the cerebrospinal fluid are breathing, hydration, and the heartbeat. But we've got this beware sign here because there are some medications that can interfere with aquaporin 4. And if it does that, then you get a decrease in the exchange of fluid between the cerebrospinal fluid and the interstitial fluid. So those three there, breathing, heartbeat, and hydration, they're critical to that flow. We're going to talk a little bit more about some of the other factors and, in fact, how they all in detail relate to that transfer and why they're important as a clinician. So the key points here that you need to be hydrated because the aquaporin 4 is a water channel. You do need to breathe well because the diaphragm excursion creates a pressure differential that moves fluid through the body. There are some medications that can downregulate the aquaporin 4, and there are some nutrition intakes, i.e. food, things that you eat and drink, that can change the way that your sleep state is. That sleep state is going to be relevant for the neurotoxic waste clearance. There are ways that the viscera moves or doesn't move that could change the interstitial flow. Same with lymphatic flow and congestions. And of course, the movement of the body through the musculoskeletal system can also impact on that interstitial fluid flow. So let's dive a little bit further into some of the other anatomy that's not just around the brain and those neck lymphatics. We're going to have a look at the esophagus. It's pretty relevant to clinicians in a way that perhaps you've not seen before. Now, the esophagus does have implications for manual therapy because it's attached to the lower cervical vertebrae as well as the thoracic vertebrae through the prevertebral fascia. And it's got skeletal muscle and it's got smooth muscle in the distal 2/3. Now, it's supplied by the vagus nerve, which travels extensively from the neck through to the thorax and beyond. And the vagus nerve is responsible for motor functions, parasympathetic motor functions of the esophagus, and the glands as well. Now, that vagus nerve is sitting very close to the sternocleidomastoid muscle on the side of the neck, and it's going to play a role later in some of the manual therapy that we do. We often find that if you do treatment around that area, you stimulate the vagus nerve in a way that you can tell, and we call those tells. Further, the esophagus is also innervated by spinal nerves from T1 to T10. That's of the sympathetic trunk, and there's implications for that, meaning that if you're doing manual therapy to the thorax between T1 and T10 or the ribs, then you may intervene in a way that causes a change to the sympathetic nervous system's behavior. Again, you listen for tells in the way the body's behaving and for changes in behavior of the esophagus. I know you're wondering what I'm talking about, but you're going to hear trickles of fluid and you may observe the patient swallow. When those two things occur, you've just seen a tell, and it's related to a change in the nervous system's output at the esophagus level. Because that esophagus is attached to prevertebral fascia at the cervical spine and thoracic spine, it demands that we then go and recheck cervical spine and thoracic spine movements and pain. Now, that vagus nerve goes all the way down into the thorax and down into the abdomen as well. So we've seen that it travels extensively beyond the neck. It's responsible for parasympathetic motor functions of organs as well as gland secretions. Secretions, there's that fluid sound again, okay? The other reason the esophagus is important is because it can refer pain to the front of the chest and also to the mid-thorax, just like many other organs can refer pain. And if you see in this chart here, we can see, for example, right upper trapezius. It's an area that can be referring pain from liver, gallbladder, duodenum, and there's a few other areas that you can see there as well. So for those of us who are treating musculoskeletal pain of the upper trapezius or the mid-thorax or the front of the chest, it's not always a musculoskeletal problem. So let's have a little further look at the esophagus and how it's linked to the cervical spine. So we're circling here the anterior scalene, a muscle that we're probably familiar with as its relationship to neck movements and also apex breathing. But just to the side of that, we have this prevertebral fascia, which is very closely linked to the trachea and the esophagus as well. Now, that prevertebral fascia, it connects the esophagus to the bodies of the 6th through the 8th cervical vertebrae. That means that there are implications for the way that we observe the behavior of that 6th to 8th cervical vertebrae. And if we're mobilizing that 6th to 8th cervical vertebrae and we detect a trickle or a swallow, you may have just stimulated movement through the esophagus And that means that we've got a possible change throughout the whole vagus system, or at least regionally at the esophagus, in the cervical spine and thoracic spine. Now, the thoracic duct is a little bit off to the left of the lower neck there, and it can be found on the left-hand side of the sixth cervical vertebrae, which you can see there circled on the left of screen. On the right of screen, you'll see the thoracic duct circle. Now, that's been peeled back just for this particular diagram. But drainage into the thoracic duct from the deep cervical lymph nodes is achieved by drainage of the proximal third segment of the esophagus. Again, we've got this implication for why that matters to us. Well, you can mobilize the hyoid cartilage, the thyroid cartilage, and the cricoid cartilage. And if you mobilize that and you get an improvement in drainage of the proximal third of the esophagus, that's going to drain into the thoracic duct. And we can see that that thoracic duct later on in the other slides is a central drainage point for many parts of the body and the musculoskeletal system. Now, the esophagus is also linked to the upper thoracic spine through that prevertebral fascia that you can see as a white structure indicated by the red arrow. So the esophagus is just in front of that, as well as a green thoracic duct. Again, thoracic spine movements will change the prevertebral fascia's behavior. It might change the esophagus behavior. We may detect that as a gurgle or a trickle. That may influence the thoracic duct. And when I say it may, I'm going to tell you from experience, it does. And that's when you go and check your biomechanical tests and your movement tests. And after you've listened for and heard a tell, you're going to observe some changes somewhere in the assessment if your assessment is reliable and standardized. That's why I use the selective functional movement assessment, because it keeps me honest. It's objective where my subjectivity might take over. Let's look a little bit further. We've got the esophagus sitting in beside the lungs, behind the trachea. We've got a lot of lymphatic flow through there. And the drainage of the esophagus in the thorax, that's in the proximal part of the thorax, it drains into mediastinal lymph nodes. And then the middle third and the lower third, well, they're also going to be implicated in our T1 to T10 manual therapies and behavior of the sympathetic trunk and those kind of things. Now, the lymphatics of the distal third, they ultimately drain into the gastric and the celiac lymph nodes around the back of the diaphragm. So therefore, we've got the implications of respiratory forces. Therefore, a diaphragm that's breathing appropriately, we call that functional breathing, may influence the flow of celiac and gastric lymph nodes. Again, if you've got gastric and celiac lymph nodes being influenced by diaphragmatic forces, you may have an improvement in drainage of the esophagus, and that shows up as a tell, being a trickle or a swallow. Now, those other posterior mediastinal lymph nodes can be seen in this next slide. So here we have the costal margins posteriorly at the vertebrae, lots of intercostal nodes. That's that third phrase on the right-hand side from the top. Lots of intercostal nodes that are close to the thoracic duct, which is the second text on the right-hand side. So again, if you've got costal movements or ribcage movements, then you can influence the flow of fluid through the thoracic duct, and it may be that if you improve that flow, you've got a chance to change what's happening above and peripherally and also beneath. So let's look a little bit further now into the abdomen. If we have a look at the abdominal system, we've got some skin and we've got some organs, and that's where we're going to start at the organs. We're going to have a look at the peritoneum, which is a serous membrane. It surrounds the abdominal organs, it protects them, and it provides for a smooth and wet environment in the abdominal cavity. Now, the parietal peritoneum, it lines the internal surface of the abdominal and pelvic wall. And the visceral peritoneum lines the walls of the organs. They're all part of the same piece of tissue, they're just named a little bit differently. Now, the two of them are connected via ligaments from the liver, and they've got some fancy names like the falciform ligament and the coronary ligament as well, and we've got some triangular ligaments around the liver. But essentially, it's the liver that's connecting that parietal and visceral peritoneums. Key points here. There are serous membranes in the abdomen. They're called the parietal and visceral peritoneum, and they're connected by ligaments around the liver. Now, Here's a transection in the sagittal plane of the abdominal cavity, and we've got that liver encircled, but wrapped around it is an orange serous membrane, which, because it's an organ, we're going to call that the visceral peritoneum. But just under the liver, it comes together and forms what's known as the lesser omentum. It's going to be relevant to some of the manual therapy that we do. So the key point, serous membrane, the lesser omentum, it's part of the visceral peritoneum. It's described further because it's got connections between the liver and the stomach. That means when you push on the stomach and you push on the liver, you're going to interfere with the lesser omentum's fascial connections. That's going to tug on different things because that causes changes to the tension inside the abdominal cavity. There's a chance you're going to hear fluid change. Why fluid? Because that abdominal cavity is full of fluid, and that's where the word serous membrane is derived from. It's a membrane that's producing of a serous fluid. We've also got the greater omentum, which is between the stomach and the transverse colon. That's a big four-layered fold of tissue that sits in front of all the organs. It descends from the stomach and then it wraps around underneath. It's probably got a fair bit of fat around it in me, but in some individuals it's got less fat, in others it's got more fat. It's got some sensitivity because it's full of nerves. It's also got plenty of lymphatic vessels in it as well. So it goes all the way down to the pelvic rim if you're thinking about some key landmarks when we palpate later on. Just going back there, we've said that it connects the stomach to the transverse colon in front. Let's have a look at a piece of tissue that connects the transverse colon to the posterior part of the abdomen. We're going to call that the transverse mesocolon. Here it is, transverse mesocolon in the orange box there on the right-hand side. Now that's important because of where it sits in terms of the spinal column. We're looking in that L1, 2, 3 area. It's sitting in front of the pancreas as well, and a whole bunch of blood vessels. Effectively, just as a reminder, these key points here is that we've got these folds of tissue. They have blood vessels in them. They create borders of recesses and bursae and sacs that have got fluid in them. And when there's congestion of the stomach, congestion of the transverse colon, there's possible tension on these parietal and visceral peritoneums. That has implications for where they attach to. Now, if we go a little bit further, we're going to talk more about the mesentery, which is similar to the greater omentum, similar to the lesser omentum, similar to the transverse mesocolon, except it's much deeper and it's related to the small intestine, connecting it to the posterior wall and the spinal column through prevertebral fascia. So again, it's a serous membrane, and if there are congestive behaviors or fluid flow problems in the small intestine, it's going to provide a tension on that mesentery. Okay, let's have a closer look at the mesentery, or what we call the root of the mesentery, as our little friend here is pointing to on the left-hand side of our screen. Well, on the right-hand side, when you cut all that away, you can see that the root of mesentery almost descends to the right. Now, that has implications for possible observations in our palpation findings around the sacroiliac joint or the lumbar spine facet joints because of that asymmetrical tug on the root of the mesentery of the small intestine. So here's another view of it with the small intestine still attached. Now, the duodenum, that's the beginning of the small intestine from the stomach. It's actually behind the peritoneal cavity, and so is the pancreas. Now, this is important because it's also anterior to some arteries. So duodenal congestion may change the pressure on different arteries deep in the abdominal cavity. Also, at the root of the duodenum, there's a little red arrow there on the image that is almost a viaduct. It's not quite the correct word, but it's known as the omental foramen. And it's where fluid flows from behind the liver and behind the duodenum, and it flows to the other side. So tension in all of those mesenteric folds, tension in the duodenum, tension in the liver, it might interfere with serous flow. When it changes, you can hear fluid flow. When you hear that, that's a tell. And if you hear a tell, you have to suspect that there's been a change in behavior of some systems. And if there's a change in behavior in some systems, it's possible there's a change in behavior in musculoskeletal system. In my experience, inevitably there is. And if your assessment findings are paying attention, you'll detect a change, and that can show up in movements and pain as far as distal points in the body, a long way away from the spine and the viscera. So, manual therapy to the liver, it could interfere with the omental foramen fluid flow. Manual therapy to the abdomen in the area of the duodenum, it could do the same thing. And if you hear that change, you're going to be looking at a different behavior of your local biomechanical tests. Let's have another look at this same region and where it sits in terms of the thoracic spine. We've got that pancreas, duodenum, we've got the ascending and descending colons on the left and the right hand side. These are some key landmarks. Effectively what you need to know is they sit south of T12, so from L1 downwards. So tensions in that area might be part of the reason that there's movement dysfunctions in and around that lumbar spine. Also, let's have a look at psoas. Psoas is circled there on the bottom left-hand side. It's going to be behind that ascending colon, and it's up alongside the inferior vena cava. Now, this is important for the following reason as per this next video. I'm going to point out how futile it is to go looking for the psoas muscle because of all of the tissues that sit in front. So on that left-hand side, we've got ASIS, then we've got skin. If you go skin, subcutaneous tissue, external oblique, internal oblique, transverse abdominis, and then you hit the abdominal cavity. And then you've got the greater omentum, which has got 4 layers of tissue plus some fat. And then you've got small intestine, then you've got the large intestine, and then you hit the posterior wall of the parietal peritoneum, and behind that you've got psoas. So I would basically have to go through all of those different layers with no sensitivity before I could feel any tissue texture abnormalities in psoas. By the way, psoas wasn't implicated in this test as being dysfunctional because he had at least a neutral or parallel thigh. So I'm looking for a difference between pressure and sensitive. Would you consider this pressure or sensitive?
Pressure.
Now the anterior abdominal wall is going to be about 3 centimeters deep, which is in the vicinity of about the first phalanx or the distal phalanx on the thumb. That's about 3 centimeters. It's obviously give or take. So if I was to submerge myself approximately 3 centimeters, I'm testing for the compressible nature of the anterior abdominal wall to see whether there's any difference between pressure and sensitivity. Would you say pressure or sensitive?
Pressure.
I'll now go deeper. It's going to be a firmer pressure, but I'm starting to hit the greater omentum, small intestine. Pressure or sensitive?
Pressure.
And now it's quite firm. So the tissue under here is either congested or packed or massive. Tender or pressure?
Pressure.
Okay, so it's a firm pressure there, and we're okay in terms of how sensitive that tissue is. I move laterally and I get the descending colon.
Pressure.
And it's quite soft.
Thank you.
You're welcome. Pressure or tender?
Pressure.
And I'm up under the rib cage, so I'm starting to catch a little bit of the stomach, maybe the transverse colon. Pressure or tender? Sorry, pressure or sensitive?
Yeah, sensitive.
Sensitive there. Transverse colon is a little bit sensitive. I come down to the transverse colon, descending colon, so anywhere in here is going to be small intestine. Pressure or sensitive?
Sensitive.
Okay, we arrive now at a couple of interesting structures known as the colic flexures. So we've got the left and the right colic flexures. I would also call them the splenic flexure and the hepatic, which is describing that they change direction or they flex under the spleen and the liver. Relevant because they could be a congestion point, much in the way that a hose, if it's kinked, might congest the flow of fluid. And you'll also notice that there's an arrow, which is the omental foramen into the omental bursa. So that's an area that allows fluid to flow. And when you're palpating liver, stomach, duodenum, or those flexures, you may influence the pressure in the cavity and that may show up as a fluid flow through the omental bursa or the omental foramen. So we have another look at the abdominal wall because we're looking for some key landmarks here. So the cecum, on the picture on the right-hand side, that cecum there, it's medial to the right anterior superior iliac spine. Now the liver, it's under the right lateral ribs and it covers much of the stomach and the proximal duodenum. The transverse colon, well, it's actually above the umbilicus and it's under the rib margin. So if we just put a little line here, we've got the transverse colon here, this is in red, and then we've got that liver sitting all the way up in there with our stomach. So it covers some of the stomach. That's our ascending colon there with our cecum. Our descending colon's actually hidden behind much of the small intestine. Okay, beware of the possible effect of restricted fluid flow in the abdominal cavity on hip mobility or sacroiliac joint behavior or lumbar spine behavior, as well as pain with movement in any of those structures. So the uterus and the bladder sit inferior to the small intestine and the sigmoid colon, and so if you're worried about palpating them in females who've got period pain or who've had endometriosis or surgery, or in fact whether you're just pushing on a inflated bladder, you do have to get quite inferior to get to that tissue. In the next slide, we'll have a look at how it lines up relative to the pelvic bowl. We can see that the top part of the uterus doesn't really ascend a lot above the inferior iliac spine and the pelvic rim at the pubic symphysis there. So the other ways you can look at it is that acetabulum. It's almost in line with the acetabulum, the uterus there. So that brings us to the sigmoid colon and the duodenum. The sigmoid colon, as being pointed out by our friend there, there's this foramen there that allows the flow of serous fluid, and it moves between what we know as the intersigmoid recess. So fluid moving there possibly affects the tone of the parietal peritoneum. Let me say that again. Fluid moving around the sigmoid colon might actually affect the tone of the parietal peritoneum. So that could change the mobility of hips and pelvis, lumbar spine, as well as movement of those areas. So it's worth checking the breakouts and the local biomechanical evaluations after a fluid flow tell occurs. So if we have a look at the back, the abdominal organs from the back, and we use the guide that's listed on the right-hand side from T12 to L4, we can get some understanding of what some of the key landmarks are when we're doing manual therapy or manual assessment from the back. We see the outline of the stomach, and that'll correspond to the orange line of the stomach. And this goes up as possibly as high as rib 8, definitely rib 9, 10, 11, and 12. Then, of course, we see the outline of the parietal pleura, being the lungs. Now, that's going to be present within the thorax to as low as rib 12. So if you're pushing away on rib 12, rib 11, and you hear some fluid flow, then you've possibly pushed a little bit of fluid through the lungs, or not necessarily the lungs, but the pleura around it. They're actually going to drain into the mediastinal nodes, and again, they go into the thoracic duct. And as soon as you hear that fluid flow, it's worth checking some of the local biomechanical tests that relate to this region. The descending and ascending colons, they're more lateral, but once you get to the iliac crest and L4-5 areas, the influence of manual therapy on those lumbar spine vertebrae will be related to the possible attachments of the parietal peritoneum. And any serous flow changes, well, you can take note of those when you're doing manual therapy around the lumbar spine and sacroiliac joint regions.